So here's a example of a spontaneous breathing patient. This is the distribution of ventilation seen with the PulmoVista 500. This is a patient on pressure support ventilation. We did a PEEP study, titrating the PEEP right up to 14. As you can see here, the left dorsal region, there's no ventilation. So we did the PEEP, incremental PEEP study in an attempt to open up that dorsal region. Here's the actual PEEP study, and when we did from 8 to 14, on the right of your screen you see that orange, that means over distension. So we were able to get a little bit more distribution to the dorsal area with the higher PEEPs. However, with the orange that you can see over here signifying over distension and a loss of compliance in that area, it wasn't an option to use that higher PEEP because it would have put in danger the ventral area of the lung to over distension. So here's just the full screen image that you can use when you're outside of the room. It's bigger, you can see it from far, and yeah, you still see the left dorsal area. So we put the patient on APRV in an attempt to open up the lung. We had some modest settings. The P high was set at 20. We had an initial T high, I believe, at 4 seconds. We were using the auto release option. And this is what the tomography looks with the APRV. And as you can see, that left dorsal region has completely opened up. Here's an image of the next day. So we see that the APRV was able to correct the left dorsal region. There was less over distension seen on the ventral areas. Because recruitment is pressure over time, when you're using APRV, you can increase the time, and very often you require less pressure. So this is a good option if ever you see that there's regions that are not ventilated. It's always worth doing a run of APRV to see, because as you know, with the higher PEEPs, we were causing over distension, and that wasn't the case with APRV.